If you run a law firm, you already know every missed call could be a missed case. But when you're in court with a client or buried in paperwork, picking up the phone just isn't always possible. That's where Posh comes in. With Posh, every call is answered like it's your most important one. New leads are captured and scheduled so your pipeline keeps moving without interrupting your day. Don't lose another case. Start your 7-day free trial at posh.com or call 833-GET-POSH.
Hello, welcome to Brief Encounters at the DC Bar Communities. I am Robert Howard from the Health Law Community Steering Committee. Today we have an exciting topic. We're going to discuss food is health. And we have two spectacular, well-qualified panel members today, Remi Mehner and Amaru Sanchez. First panelist is Remi, who is a counsel in Akin's healthcare and life sciences practice. Her practice spans both the healthcare and food and beverage sectors, where she advises clients on complex regulatory, enforcement, and policy matters, including provider reimbursement and fraud and abuse compliance, as well as food regulation. Drawing on her work across both sectors, Remi offers a grounded perspective on why food is health is increasingly showing up in healthcare policy conversations, and what healthcare lawyers should be watching in the food space. She holds a BA from Wesleyan University and a JD from Harvard Law School. Our second panelist is Amaru. He is a counsel in Akin's healthcare and life science practice, where his practice centers on FDA, USDA, and related regulatory and policy matters concerning food, beverage, and agricultural products. Before stepping into a legal career, Amaru spent several years working in the public health space. This background enables him to approach food as medicine from both a legal and regulatory perspective, as well as a broader public health lens. He holds a BA in integrated biology from the University of Florida, a Master of Public Health from Boston University School of Public Health, and a JD from Catholic University of America, Columbus School of Law. And again, I am Robert Howard. I am the co-chair of the Health Law Community Steering Committee. I hold a bachelor's degree cum laude from Hampton University in biology, a doctor of medicine from the University of Virginia, and a Juris Doctorate cum laude from Notre Dame Law School. So let's start this conversation. Exciting topic. So let's start with the overview of food is medicine. Remi, give us some background, some key terms that attorneys should know about.
Yeah, so thanks again for having us, Robert. We're excited to talk about this topic. But in terms of an overview, there's actually no standard definition of food as medicine. However, at its core, food as medicine generally refers to targeted evidence-based nutrition interventions that are integrated into healthcare and are designed to prevent, manage, or treat specific chronic diseases. So think type 2 diabetes, hypertension, heart disease, and obesity. Popular initiatives under this space are one, medically tailored meals, MTMs. And these are fully prepared home delivered meals that are tailored to the medical needs of individuals living with severe or chronic illness. They're often tailored by a registered dietitian nutritionist. So an example of that is a patient with diabetes, and they may receive medically tailored meals that are designed to support glycemic control. Another popular term under this space is medically tailored groceries. So similarly, these are tailored, but instead they're pre-selected uncooked or unprocessed foods that are, again, targeted to address specific needs and health conditions. And then a third popular term under this umbrella is produce prescription programs. So here you'll have a doctor prescribing predetermined dollar amounts of fruits and vegetables to patients based on specific dietary needs. And they come in the form of perhaps a voucher or an electronic benefit card that patients can redeem at a local retailer or their local farmers market. And then there's also nutrition counseling that's, again, integrated into care management. So that's all to say that this is beyond just general advice to eat healthier. These are structured nutrition interventions that are tied to a patient's care plan. And none of this is entirely new. The connection between nutrition and health has deep roots in public health programs, anti-hunger efforts. We saw this with the HIV/AIDS care popping up in the 80s, WIC, SNAP, But what is new with the food as medicine movement is that these ideas are being formalized into healthcare financing and delivery models.
Yeah. And the only thing I would add to that, Remy, is what you just said, really kind of jumps out at me is that concept that these interventions aren't new, that this had been around for quite some time. Like Robert introduced me, prior to becoming a lawyer, I was, getting my master's in public health in Boston. And I saw that connection for the first time, between nutrition and health. This was like in the early 2000s. At that time, I was working at Boston Medical Center, working alongside nutritionists who were helping patients kind of manage their weight and chronic conditions through some of the examples you just highlighted. And also on the weekends, I would help them run these sort of volunteer community resource programs like farmers market, where again, like there's that connection of eating nutrient dense food in order to kind of manage these chronic conditions. And that was, unfortunately, that was the first time I really saw that meaningful overlap and the real changes that it can make in someone's health and lifestyle in general.
But tell me, why should healthcare lawyers, why should we start paying attention to this topic?
Yeah, no, great question. So, as soon as you start integrating food into healthcare, the legal issues multiply, especially because there's so many different players involved. So, we're talking about health systems, payers, Medicare Advantage plans, digital health companies, grocery and delivery platforms, and community-based organizations that are doing this work on the ground, like Amar mentioned. So, once these groups start partnering, you're going to trigger health law questions that a lot of us deal with. So, some key issues: reimbursement, which is where some of my practice lies. If a Medicare Advantage plan or Medicaid program is paying for the food, what is it? Is it a medical benefit? Is it a supplemental benefit, a waiver service? These classifications matter. You also have scope of practice. So who is allowed to provide these type of nutrition services? There are states that regulate who can provide nutrition counseling, medical nutrition therapy, and related services. And so, depending on the model, you may have these different players. But then you also have vendors who may not think of themselves as healthcare providers that are acting as such, and will have to navigate the regulatory landscape. So, these vendors or digital companies that are helping bridge the gap between the patient's conditions and helping get them connected to the organizations that are providing these medically tailored meals or these medically tailored groceries. Fraud and abuse, another area that I work in. Anytime you're giving patients free or subsidized benefits like meals and groceries, you have to think about the anti kickback statute, beneficiary and inducement rules, Stark law, especially if physician referral relationships are involved. There's privacy and data sharing. These programs often require sharing patient data across providers, plans, vendors. So you have HIPAA, state privacy laws that could be implicated. And then there's also contracting. How do you translate a food as medicine project into a workable operating model? Operational details like eligibility criteria, clinical oversight, food safety, delivery. These are all legal and compliance questions that pop up.
Yeah. And another area where this kind of really comes up is on the claims. I mean, you really want to promote these programs, but as organizations kind of make claims about what food-based interventions can do, whether it's treating diabetes, reducing cardiovascular risk, preventing hospitalizations, or improving, some sort of health outcome, it's really important that folks step back and just make sure that those claims align with what's legally permissible and aren't misleading to a patient. I mean, the more medicalized those statements become, the more folks need to really think about the regulatory overlay, FDA implications, FTC, Federal Trade Commission consumer protection risks, potential scrutiny from state attorney generals, and even how these representations, hold up in payer contracting, as Remy mentioned. At a very practical level, the concern is that you don't want patients relying solely on food to manage their chronic conditions at the expense of taking prescribed medication or following what their provider's advice is. So the bottom line is, once food starts to intersect with healthcare, delivery, or financing, you're no longer just in the nutrition space, you're squarely within sort of health law territory. Absolutely.
That's a great point. Let's talk about kind of the federal regulatory landscape, federal actions and our signals from our federal partners. So Secretary Kennedy has made that phrase, make America healthy again, take back our health. CMS had some signals that they are possibly engaging in this space. Tell us something about the federal regulatory landscape as far as food is health, food is medicine.
Yeah, definitely. A lot is happening in that space, as you mentioned, Robert. So we're getting strong federal signals pushing the food as medicine movement forward that isn't just tied to one administration. So as we mentioned, Maha, Secretary Kennedy's agenda that he's been pushing forth, but it's important to note that the food as medicine movement dates back to the 60s and 70s, where doctors were literally prescribing food to treat malnutrition. And even before the Trump administration, the Biden administration came out with a national strategy on hunger and nutrition. I believe this is in 2022. So, as you mentioned, we now have the MAHA movement. Food and nutrition policy is central to this agenda. The administration has framed ultra processed foods, additives, sugar consumption as major drivers of poor health outcomes. As you mentioned, also, Robert, we have Secretary Kennedy taking this tour on the road, the Take Back Your Health tour, promoting new dietary guidelines and emphasizing eating less processed foods. But we're also getting more subtle signs. So, most recently, this past spring, CMS issued guidance to hospitals reinforcing hospital obligations under the conditions of participation. And it emphasized consuming nutrient dense foods, limiting added sugars, reducing ultra processed foods, and overall just aligning hospital meals with dietary guidelines. So while it's not entirely clear how operational this becomes, from a compliance perspective, these signals matter.
And also, we're also seeing that sort of in other federal programs across, notably, these themes, that Remy just mentioned, really align with priorities USDA has been emphasizing, particularly given the recent issuance of the updated dietary guidelines and how that's intersecting with child nutrition programs. Program operators for these school programs were encouraged earlier this year to get familiar with the updated guidelines and really think practically about how to incorporate those recommendations, like the greater focus on whole foods, less processing, to really think about that across all federal supported meals. And that's like, the National School Breakfast Program, National School Lunch Programs. And, it's also worth noting that in case folks are not familiar, updates to dietary guidelines really is just a starting point. They kick off sort of this longer process of program alignment, procurement standards, and product specifications, again, to making sure that meals served in schools in this instance align to the best they can with the updated dietary guidelines. And that alignment doesn't happen overnight. It plays out over time through notice and common rulemaking, which we know doesn't not happen overnight. And there's a lot of fairly significant administrative actions, and stakeholders participating in federal nutrition programs really need to work through how to operationalize those recommendations when they come. And a proposed rule is imminent on how we're going to see that really come to fruition.
Yeah, and I think Remy mentioned, sugary snacks and sugary sodas. So let's talk about, the funding stream. I'm here in DC, but I've seen, other municipalities try to tax sugary drinks and other products. What's that all about?
Yeah, so there's different mechanisms for implementing food as medicine projects or initiatives. And that's definitely where all this comes together is through the funding. So who's actually paying for these benefits? And that's how you see how food as medicine is being operationalized inside the healthcare system through reimbursement structures and funding mechanisms. So as we know, traditional Medicare doesn't cover the direct provision of food. However, CMS over recent years has been encouraging states to use Medicaid flexibilities, especially Section 1115 waivers, to cover nutrition supports for certain populations as a medically appropriate way to address health related social needs. So you're seeing programs targeting pregnant individuals, folks with chronic diseases we talked about, hypertension, diabetes, folks transitioning out of institutions. And currently, I think there's maybe over 10 states, including California, that have Section 1115 waivers to implement food as medicine demonstration projects, including medically tailored meals and groceries, like we discussed. On the Medicare side, there's Medicare Advantage, which has also been a major driver of these initiatives. So there's the special supplemental benefits for the chronically ill authority, which allow MA plans to offer supplemental benefits for this subset, this population, the chronically ill, including food and nutrition support. So this looks like meal allowances for healthy food and produce, pre-funded debit cards for groceries, and these type of benefits have substantially grown since this authority became available, I believe, in 2018. In 2025, there were almost 2,000 MA plans that included food and produce benefits, and that's compared to about 100 in 2020, which is pretty notable given that 35 million people are enrolled in MA. And then also there's private grant funding. So it's not just tax dollars driving these initiatives. There's a pretty significant amount of private and philanthropic investment coming to the space. One major policy organization driving this is the Center for Healthcare Strategies, and they have a food as medicine initiative that's designed to help states build capacity for these projects. So, like funding dedicated staff, providing technical assistance, and coordinating these food as medicine programs across Medicaid and other public health agencies. You're also seeing investments going directly into community programs. In the DC area, there's Food and Friends that, it's a program to support delivering medically tailored meals to folks with chronic illness like diabetes, HIV. And yeah, there's a lot of folks doing this work on the ground. So there's a lot of different funding streams that kind of work together to keep this movement going.
Yeah, so let's drill down a little bit. So you mentioned government, possible funding sources, and private sector. So let's go back to government and we'll follow up with private sector. So initially, I think you said that Medicare does not pay directly for food assistance. However, you mentioned Medicare Advantage, which that's the managed care portion of Medicare. Tell us about Medicare Advantage and some possible benefits in connection with food as medicine, food as health.
Yeah, so definitely that's something that the government has definitely been encouraging plans to do to offer these supplemental benefits. They look like, meal allowances. When folks try to sign up, you may see an offer to say, like, sign up for X MA plan, and it includes X amount of preloaded money to buy produce and food at your grocery store. So this is something that's definitely increasing over recent years. You're seeing a lot more plans offer these type of benefits, which it is really important because again, the crux of it is paying for it. And the idea behind this whole movement is that on the long term, it's going to save the government money, right? The idea is it's cheaper to feed folks and allow them to have proper diets that can help manage these illnesses than a hospitalization.
I know we're going to have a lot of lawyers listening to this podcast, but Medicare versus Medicaid. So Medicare, we're thinking folks over 65, folks with chronic kidney disease, disabled, and Medicaid being low income, disabled, and other categories. So what's happening on the Medicaid side? I think you mentioned 1115 waivers. Tell me a little bit more about that.
Yeah, so Medicaid waivers essentially is states asking for permission to experiment with their Medicaid programs. So a lot of these states have pending approvals or have approvals where they ask the government if they can implement these food as medicine initiatives into their Medicaid programs. So we've seen quite a few states do this, including California, where they're allowing folks under the Medicaid program to receive these medically tailored meals, groceries, prescription, as a way to address these health related social needs that, aren't traditionally underneath Medicaid authority.
And you mentioned California and medically tailored meals. What is a medically tailored meal? Like, I know I need to eat more fruits and vegetables, but what exactly is a medically tailored meal under a Medicaid, Medicare, or privately financed assistance program?
So these are often home delivered because the idea is that it's also targeting folks that may not have access to these types of food. So a registered dietitian nutritionist tailors it depending on the chronic illness or the severe illness that the meal is trying to manage. So this could be, I'm thinking like for hypertension, maybe it's already cooked food that may have like lower sodium levels. And these are, again, delivered to folks to help with food access. And then also, what they're doing is tailoring it with nutrition counseling. So, in addition to providing the meals or providing the groceries, you may have access to a nutritionist, talk about cooking skills, how to prepare these meals for yourself, what to eat, maybe looking at the pyramid table and talking about what certain ingredients or what certain types of food are, best to help manage whatever health condition you have.
Yeah, that's very important. So not only delivering meals, as we say colloquially down the South, don't give me the fish, teach me how to fish. the nutrition programs for folks who are battling chronic diseases, it's very important. So we're talking about prevention and how we save healthcare dollars. Don't wait until someone has, a condition that's out of control, which could have been maybe ameliorated by these steps, by food is health, food is medicine, a nutritionist teaching you how to eat well, exercise and diet. So very important in the healthcare space when we always talk about, how much we spend on healthcare in the States. So we talked about the federal landscape. So we talked about Medicare and Medicaid 1115 waivers. Did you want to talk any more about the California waiver, or can we move on to private sector funding?
Yep. So California, I think their managed care plan launched in 2022 includes medically tailored meals and medically supported foods. And the idea is that, it's a cost efficient alternative to these high cost covered services like hospitalizations and ER visits. So there definitely have been early adopters of these type of projects for sure. And then, yes, like the private grant funding, there's folks on the ground outside of federal dollars that are really believe in this movement, and then probably even before we started getting these federal signals we're doing this work, because like we said, this isn't a new initiative. There's lots of grants supporting produce prescription programs, private grants covering these medically tailored meals. There's efforts on the ground to connect these like health systems to local food producers or farmers. I know I've seen at certain farmers markets, them passing out vouchers to low-income folks to have them have access to these whole foods, healthy veggies, healthy fruits. So yeah, so the private sector is very much involved and working in this space.
Yeah, so you mentioned farmers markets. I think this topic is very exciting and for the positive benefits that it can have to all of our communities. There are benefits such as SNAP, used to be called food stamps, Supplemental Nutrition Assistance Program, which also has some states have benefits where you can get fresh fruits and vegetables. So why is food is health, food is medicine different? Why do you need waivers? Why do you need private funding? Why can't we just, increase your SNAP benefits or you get fresh fruits and vegetables under that program? What's the difference in food and health versus what's already in place?
Yeah, 100%. I think that's a good distinction to make. So you do hear the broader framing, food is health, but this goes beyond clinical care because, again, food is medicine are these structured nutrition interventions that are specifically tied to a patient's care plan. But you mentioning WIC and SNAP, that goes under the broader umbrella of food is health, and it captures things like what WIC and SNAP does, food access. Also under the umbrella is labeling, additives, school meals, and it's essentially the overall food environment. So I think where food as medicine is getting at is that you're integrating this idea of nutrition into the healthcare system, and hopefully the healthcare system is funding that for better health outcomes.
Yeah, so you mentioned WIC, which Women, Infants, and Children's program, I think for prenatal, postnatal moms and kids, a nutrition assistance program. So we have WIC, we have SNAP. You want to get good nutrition in general, make sure everybody has an adequate funding source for daily nutrition, but food is health slash food is medicine is more tailored to the individual. So, chronic heart disease, I have diabetes. This is more than just I'm giving you benefits to buy what you want. I'm actually a medical professional, a clinician, a nutritionist is tailoring your food intake for your benefit. So it's much more detailed than programs that people may be familiar with right now.
Right. Exactly.
So we've covered a lot. We've covered the terms. We talked about funding streams. Let's do a little rapid fire. What should folks in the healthcare law space be looking for in the near future? What are the kind of developments that you see on the horizon?
Oh boy, there's a lot of development, especially in the FDA food space here. And I'll throw another new term at you and the listeners. There's something called GRAS, which is generally recognized as safe. It's a legal framework under the federal food law, under the Federal Food, Drug, and Cosmetic Act that allows certain substances intentionally added or reasonably expected to be in the food to avoid a pre-market review and approval FDA has to provide. Unlike other countries, the FDA does not require sort of pre-market approval for all food ingredients. There is this sort of pathway known as the generally recognized as safe pathway. And that is for ingredients that have sort of this, quote unquote, generally recognition by scientists that their intended use at a certain level is safe. And there's been a longstanding controversy with this pathway. And that's because there's two pathways that a company can conclude that their ingredient is, quote unquote, generally recognized as safe. And the first one is submitting a dossier to FDA with their conclusion, the supporting science, and all the studies, all the toxicological studies to show that their ingredient is safe. And then the FDA will then follow up with a letter known as a no questions letter saying it's not an approval, but it's sort of a way of the FDA saying, we don't disagree with your safety conclusion. Now, the second pathway is for a company making an ingredient to self-affirm their GRAS conclusion. That means that they're not submitting this dossier to the agency, that you just sort of keep it in their file. Both pathways are legally permissible. So the controversy lies sort of in the second pathway, which many kind of frame it as sort of this like secret sort of ingredient program, the secret GRAS, this loophole, since no one other than the company, self-affirms. Now, the policy debate here is whether the current system provides enough kind of transparency and oversight, especially for food chemicals that may have been used for years, decades. I mean, there's some ingredients that receive generally recognition status by FDA that's 20, 30 years old. And as we've seen, I'm sure you've seen the headlines, especially under the current administration, recent federal and state attention to food additives has really increased for reform. We've seen states really taking the lead on this and restricting certain food ingredients, which is creating a little complicated compliance landscape for food manufacturers. When you have one state banning or restricting, these 5 ingredients, you have another state restricting or banning another set of ingredients, that becomes a little bit of a problem, for food companies that operate on a national scale. But for health lawyers, their relevance is just broader than just FDA counseling. Healthcare organizations that procure food, operate cafeterias, contract with meal vendors, or, as mentioned earlier, make these health-related claims about food quality may need to monitor these additive policies and supply chain representations to make sure they're maintaining compliance. And, as I mentioned, it's a little hard now with a patchwork. Another term I'm sure we've heard a lot is sort of ultra-processed foods. I mean, that's become a flashpoint these days. But the issue is that there is no single legal definition for what is an ultra-processed food that applies across all programs. But it's in the works. Earlier this year, FDA and USDA issued what's a request for information to help kind of develop this uniform definition of processed food. Now, that definition matters, right? If policymakers restrict ultra-processed food in schools, in hospitals, in federal programs, Medicaid funding nutrition support, or even health plan benefits, the definition is really going to impact all these stakeholders and patients. So what counts as ultra-processed food? We'll see. Another big one, this is more on the nutrition side, on the labeling side, is front of package labeling. I'm sure folks have seen when they buy their food, you have to turn the package around and then you see the famous nutrition facts panel. But now there's going to be a front of package labeling that is pretty much a summary of really specific healthcare information right in the front. And FDA has been working on this approach for making, nutrition information more accessible to consumers, particularly around certain high-value information like saturated fat, sodium, added sugars, and overall diet quality. For health lawyers, this matters because labeling policy can influence a consumer's expectations, product reformulation, institutional procurement, and litigation risk. If the regulatory environment moves towards clear warnings or some sort of interpretive labels, food companies and health-focused partners really need to assess these marketing claims. And then lastly, we kind of got into this as sort of the state patchwork. States feeling that the federal government is not moving fast enough or just listening to their constituents, are increasingly becoming very active in the food policy space. On the legal questions around that is whether state laws are preempted by federal law. How do companies manage this sort of inconsistent requirement, this patchwork? And for healthcare organizations, the state patchwork can, again, affect some of the areas that we talked about: procurement, patient programs, Medicaid managed care requirements, and partnership with food vendors. So there's a lot of, happening in the FDA space, but it really sets the tone for a lot of other impacts across the healthcare system.
Yeah, oh my goodness. That was so much great material for lawyers, new and seasoned attorneys in our field. So I can't imagine the state versus federal preemption question when it comes to food. So, no foods get shipped to DC and Virginia and don't get shipped to North Carolina. I think that's probably a rarity. So how do you manage federal regulations versus state regulations? Do you preempt it? I don't see how you don't. Like, how can you have a patchwork of 50 states and the territories for food? The marketing and the labeling of food products, the back of the box versus front of the box, manage your clients well, read the regulations, read what's coming out of the pipeline. And I think we had a lot of alphabet soup there. I don't think we we defined all the terms. So we practice in this space. So HHS, Health and Human Services, federal government department, and a part of that is the Center for Medicare and Medicaid Services, which is the federal partner for Medicaid and Medicare. You also mentioned the USDA and the FDA, so Food and Drug Administration versus USDA, which is the federal partner for SNAP benefits. We can have a whole conversation on this last couple of minutes that you mentioned, the developments on the horizon.
Absolutely. I mean, it is really, and food has really become front and center, not only on the regulatory front, but, as Remi mentioned, food is health is really becoming sort of the guiding star, and that's really motivating a lot of these movements and has been a huge impact on how the food and healthcare landscape will look like, in the coming years. We're going to see a lot of activity. We're expecting a lot of activity in the FDA and USDA space that will really set the tone for the next couple of years.
I want to thank you all for this exciting and timely conversation, Remi Mehner and Amaru Sanchez. And thank you, DC Bar Health Law community, for joining us today. And hopefully we'll have another conversation in the near future. This is an exciting, developing topic. Thank you all.
Thank you, Robert.
Thank you.
This episode of Brief Encounters was brought to you in part by our sponsor, Posh. Start your 7-day free trial at posh.com or call 833-GET-POSH.